thank you to everybody for your patience. I'm just going to go ahead and, Brandon, ask you to advance the slides for me, if that's okay.
Sure.
Number one, thank you, everybody. 340B policy is not the easiest thing in the world, but it feels a whole lot easier than technology these days.
Sounds good, Colleen. And just so you know, we're on the agenda slide, and I've left it there.
We're on the agenda slide. Okay. Okay. Well, why don't we move on next to our next slide? And the picture on the slide will look very familiar to the gentleman who just spoke. I wanted to introduce, make sure everybody here knows Brandon Jones. Brandon, you joined what, about 2 months ago now? You joined NAC?
3 months, 3.5.
3 months. Okay. Okay. Well, time's sort of surreal these days. Brandon is our new Director of Health Center Operations and HR Training and Pharmacy. He's in the Training and Technical Assistance Department. Pharmacy falls under his very broad purview. And so for those who might not have heard, I'm going to be leaving NAC. My last day is Friday the 4th. Of December. So Brandon is going to be taking over responsibility for office hours from here on out. Brandon, I can't say I envy you the technical aspects of this, but maybe you'll be more successful with this than I have been.
We'll get it fixed.
So thank you, Brandon. I appreciate that. So for those who haven't heard, I'm actually not leaving the health center world entirely. I'm going to go, I'm going to be working directly for the state primary care associations. So you still will be seeing me around, but not so much in the pharmacy operations space, but just back in my, I guess what you call my native habitat of policy and regulation. So I'm going, but not really going all that far. So, but many thanks to Brandon. I know you were in excellent hands with him going forward, as you can see from his bio here. So, okay, let's move on to the next slide. Oh, wait, I even had the wrong slides up here. Oh, goodness gracious. This is a mess. Hold on 1 second. 11-2. Okay. My next slide was actually supposed to be just a reminder of the fact, or maybe I skipped over this one, that office hours is an event that is sponsored by the Bureau of Primary Health Care. It is paid for with federal dollars. And as a result, it's really important that we can talk about facts in this session. We can talk about what's happening and what's going to happen, but we cannot talk about advocacy. So you'll hear that I'm just going to be very factual about some updates. So we're going to follow our usual presentation format, which is some operational updates followed by a focus topic, which is a little deeper dive into the question of in-house pharmacy and whether or not that makes sense for a health center that maybe doesn't have an in-house pharmacy right now. Given everything going on with contract pharmacy, there has understandably been a real uptake in interest in that question. And then we'll end as usual with some just general Q&A. But the first topic I wanted to talk about, could somebody, I'm going to send John Malik, if you have the email, the link to the new meeting. Yep. So thank you very much. The first thing I want to say is that, I always have analogies for what it's like living in Washington. And for the last several months, it's really felt like living in the midst of a hurricane because there was so much noise and so much wind, and it was all you could do. It felt like some days to stand up and get yourself heard above the din. Well, I now have a new analogy. Suspended animation, fork in the road. I went through several of these. But the bottom line is, assuming that Vice President Biden is going to be the next president, which I know not everybody is in total agreement about right now, but assuming that's the case, I think we can expect some really major changes coming down the line for the 340B program and for drug pricing and drug industry in general. For those who haven't heard, you may recall the name, if you've been around for a while, the name of Dr. Mary Wakefield. She was the administrator of HRSA during pretty much the entire Obama administration until near the end when Jim McRae stepped in on an interim basis. But she was the administrator who was in charge when they put forth the guidance about multiple contract pharmacies, when they were implementing some of the regulations that were required under the Affordable Care Act. Well, she's back in town. I'm not sure she ever even left, but she is on Mr. Vice President Biden's transition team. So I think it's pretty safe to say she's most likely going to be overseeing HRSA and as part of that transition. And she has she's a brilliant woman, very in-depth understanding of 340B. So I think her coming aboard heralds a new era in the 340B world. And just a reminder to those whose lines are open to please mute yourself if you can, because I'm getting some background noise. So next slide, please. What I'm going to do is go through the major things that are outstanding in the 340B world and talk about where I think they stand now, given the likelihood of a change in administration. First of all, the executive order that the president issued in July around health centers must charge low-income patients no more than the 340B price for insulin and EpiPens. I'm sure people recall well that there was, this administration put out a proposed rule, originally an interim final, then proposed. Many of you submitted comments on that. HHS will not say publicly, they cannot say whether or not they are going to try to finalize that rule before the president leaves office. I would bet that they most likely are going to try to finalize that before January 20th. If it goes into effect, if the rule is finalized, there are a couple things that could happen. One, of course, is that it could go into effect as written. That is always a possibility. Another possibility is that the Congress could overturn the regulation under what's called the Congressional Review Act. This is a law, it's a Newt Gingrich era law that says that Congress has the right to overturn final regulations within, I believe it's 45 days of their being published. And it generally happens when there's a turnover in administration. So clearly this regulation would fall within that 45-day turnaround period. But of course, it's not a guarantee that Congress will choose to do that. It will depend very much on what the members of the new Congress choose to, what their view is on this issue. And it doesn't always fall down party lines at all. So it's a possibility Congress could overturn it. It's also possible that the incoming Biden administration could keep pushing back the effective date. Some of you may remember the Obama administration published the regulation around civil monetary penalties in its last days with an effective date that was early in the Trump administration. And the Trump administration pushed that back multiple times before it finally went into effect, only after following a lawsuit from the hospitals. It's possible that the new administration could do that as well. So if anybody knows for sure what's going to happen, I'd love to have your crystal ball, because we don't know for sure if it's going to be finalized. We don't know if Congress is going to overturn it. We don't know if the new administration is going to push back the date. One thing we do know is that if a regulation is finalized, the new administration can't come in and just kill it immediately. Congress can do that, but a new administration would have to go through the whole notice and comment period to rescind it, the whole notice and comment process. That's why often administrations just end up delaying the effective date if they can instead. Next development, excuse me, new slide, please. Next development has to do with the refusal of some manufacturers to ship 340B priced drugs to contract pharmacies. When we last had one of these sessions in mid-October, we were saying, hey, Novartis said that they were going to stop shipping to us if we didn't turn over all of our data. They said they'd stop shipping to us on October 1st, and they haven't followed through on that threat. But they hadn't said anything public, so we didn't know what was going to happen. Well, it was right before Halloween, I believe, Novartis officially put out a letter rescinding its policy of not shipping 340B priced drugs to contract pharmacies, at least not to the contract pharmacies working with grantees. There were a couple things that were very interesting in this letter. The first thing was that they Novartis made a distinction between grantees and hospitals. And that's a distinction that health centers have often been making. You've probably all heard me say that hospitals are 80% of the dollars in 340B and 99.99% of the angst and bad press and all of that sort of thing. Well, Novartis drew that distinction, which is not something we're used to seeing in writing from drug manufacturers. So that was number one. Number two, they highlighted the fact that grantees have a lot of requirements on us already about how we have to use a 340B saving. So it was nice to see that that message has gotten through as well, that we're a different category of covered entity and that we already have these requirements. The third piece, which gave me a little bit of heartburn, was that they said, okay, grantees, you get contract pharmacies just like always. Hospitals, we're not going to ship to any contract pharmacies of yours that are more than 40 miles away. Now, on the one hand, that doesn't apply to us, so we don't particularly have to be concerned about it. On the other hand, I am a little concerned about it because it is what I would call a sledgehammer approach as opposed to a scalpel approach to dealing with contract pharmacies. They've just decided that anything more than 40 miles away is too far. Well, what about mail order pharmacies? What about if you have a drug that you can only get through a specialty pharmacy that is more than 40 miles away? So if that restriction were passed on to health centers, which it was not, but if it were, I certainly would have had some concerns about that. But the good news is that's not our problem right now. The not so good news is we still have 3 manufacturers, Eli Lilly, Sanofi, and AstraZeneca, who are continuing to refuse to ship to contract pharmacies. In terms of what happens next with this, once again, nobody has a crystal ball that will tell you how the new administration is going to respond to this. I will say that there have been many legal arguments made that an administration could put a stop to what these manufacturers are doing by fining them. And it is certainly a likelihood, a possibility that the new administration will take that approach, especially given that the member of the transition team was the one who put the multiple contract pharmacy policy in place. Next slide, please. Speaking of actions around contract pharmacies, just some factual updates around legal action. The Ryan White Clinics for 340B have filed a lawsuit around, it was kind of likened to a throw a spaghetti at the wall lawsuit around contract pharmacies. They included a whole lot of legal arguments, supposedly with the hope that one of them would stick to the wall. NAC filed a lawsuit in October, focusing on one argument in particular, and that is that the 340B statute said back in the ACA days, 10 years ago, hey, HRSA, you have to set up regulations for an administrative dispute resolution process to address issues like what's happening right now. HRSA has never finalized regulations on that. They put together a regulation in 2016. I think the comments that NAC submitted were a mere 31 or 35 pages, singled space. So needless to say, there were some concerns about the adequacy of that proposed regulation in 2016. So yesterday it was announced by OMB that NAC is, that they are dusting off that regulation that they proposed in 2016 that a lot of people had concerns with, and they're going to be finalizing it. And hopefully most likely publishing it before the end of this administration. We don't know for sure what that looks like. We haven't seen it. But what we can say is, number one, it was very problematic when it was proposed in 2016. And number two, there have been a lot more threats to the program, much more serious threats since 2016. And if there were concerns about how adequate it was in 2016, there are even more concerns about how adequate it is in 2020. Given that, NAC is continuing its plans to file a preliminary injunction to seek to get HRSA to say, manufacturers, you have to get these drugs flowing. I think that they're hoping to file that next week. So as I said, we can't talk advocacy. Just one last thing. Health centers submitted over 120 declarations of harm. Thank you for that. You will be hearing more about that. Moving on to the next slide. The Calderos rebate model, a couple updates there. Number one, about half of the members of the U.S. House, I guess this was last week, it all starts to run together, about half of the members of the House sent a letter to HHS saying, rebate model, not okay. I think it was 220, which may be just over half, was somewhere right around there. Another thing to know about Kalderos is that they have still not launched their model, which was originally scheduled to be launched on September 8th. It has still not been launched. In fact, Kalderos reached out to NAC to discuss alternatives, things like, well, maybe we just limit it to contract pharmacies. Tim Millett, Sue Veer, and I were all on that call, and we made it very clear that as long as pickpocketing is a threat, that turning over data around Medicare and privately insured patients is a showstopper for us, and that was just, in some ways, as politely as we could, sort of the end of the conversation. But just pickpocketing, if we turn over that data, it turns right around into having the money taken away from us. I also want to highlight something that Sue Veer brought to my attention, and I don't know if her line is open, but Sue, please feel free to chime in here. We've seen that Kalderos has been sending emails to health centers saying NAC recommends working with Kalderos. And we want to be very clear about the fact that NAC has recommended that you work with Kalderos when Kalderos comes to you with a very explicit list of these particular prescriptions dispensed to your patients at this time, blah, 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 we're worried about duplicate discounts. Okay, the reason we recommended that is Kalderos has been working on behalf of the manufacturers, and there's concerns that if you work with Kalderos, if you don't work with Kalderos, it could encourage a manufacturer to want to audit you. There's not even a guarantee that's going to happen, and some very thoughtful, well-intentioned people don't even necessarily agree with that recommendation. But I want to be clear with everybody that the recommendation has extended to these very individualized requests coming in from Kalderos. That recommendation does not extend to participation in the rebate model. Sue, I don't know if your line is open, but feel free to chime in there.
Sure, I just opened it, and we did post, I believe Tim posted my notice on NoddlePod, because we also wanted to make sure that responses to those good faith inquiries were also limited to only those claims in which it is a statutorily established rebate, Medicaid and Department of Defense, which is much more limited, rather than the broad brush of all claims. And the use of the NAC presentation that said to participate with Kalderos was definitely taken out of context.
Mm-hmm. Okay, two other areas of updates then, and next slide, please. Tim has been working closely with NAC's State Affairs team on issues around whether or not Medicaid drugs dispensed to Medicaid patients are covered under managed care or fee-for-service. So, Tim, you want to take this slide?
Sure, thanks, Colleen. First off, California, we just received news this week that, in fact, they are going to be postponing the carve-in of MCOs into fee-for-service. And the statement was it'll occur no sooner than April 1st of 2021. And I like the word no sooner than, which leaves us to hope that it could be later than that if they're still considering items, or, you know, if there's still opportunities there. I don't know, but that was put out this week. As a result of a number of changes in the offers that were given to community health centers, because of the savings that would be lost, it was cut almost in half, the monies that was going to be distributed to them. A group of health centers has sued the state. I don't really want to go into that anymore. That action wasn't universally supported, but it's out there, and we'll see how that transpires. New York has been fighting also the carving in of MCOs into fee-for-service. They have a very, very strong safety net coalition, including Ryan White's and community health centers. They are doing a phenomenal job of publicizing this, of working with their legislators. I can't believe all the work. I was on a call just prior to this one, a weekly call with them, just to see how they're moving. It's unfortunate. I feel they're not pushing the legislators to make any changes by everything that they're doing, but hopefully in time, just the weight of the information that's out there, public opinion could help sway these legislators. I don't know for sure, but New York is working very, very diligently to make this happen. And then just last week, we were informed that New Jersey had a Senate bill come up that would propose to again move the managed care into fee-for-service. And this would be massively devastating for New Jersey as well. And we've kind of worked together a bit of a coalition between health centers and Ryan White's and family planning centers to think about providing alternatives to the current bill, including proposing that New Jersey work toward an Oregon model. So we're staying on top of that and working closely with the PCA in New Jersey, as well as the individual entities there. One of the nice things is we do have legislators there, assemblywomen, assemblymen, that are have been very vocal that they do not want to hurt the 340B program. They had no idea that this bill would. So we feel good about that. That's really what I have to present here. Before I mute myself, Colleen, is there any more that you can share as far as what folks should be doing? Oh, you can't share what they should be doing as far as that final rule. Stay tuned to Noddlepod Advocacy, and we'll update you later today or tomorrow on that. So that's all I have. Next slide, Brandon. This would be for Sue, please.
Oh, okay. I wasn't sure. I was waiting for a cue here, I guess. I once again want to remind everybody of the upcoming 340B Coalition Winter Conference, which unfortunately will most likely not be in San Diego, but that's still a little bit iffy, but I think we need to plan on virtual. And what I'm really reaching out to you all for is just some ideas for sessions. We are spending so much of our time talking about the policy issues, the manufacturer assault. I really want to focus at least our 3 expert sessions on strategy, operational excellence, that type of thing. So if you have a best practice you'd like to share in one of those sessions or some thoughts and ideas about that, please let me know. We're getting pretty close to the wire in terms of turning in session descriptions. So shoot me an email, or if you don't have my email address, I'll put my email address in the chat box. But really looking for both ideas on sessions and speakers, and definitely please plan on attending.
All right, let's move on to the next slide, Brandon. Okay, one thing that I did add to the bottom of Sue's slide, Sue and Colleen and I had a call with Apexus this week, and we're looking at potentially working with them through NAC to help promote and possibly be part of putting together some specialized health center trainings on topics that seem to be kind of hot topics that Apexus actually can assist us with operationally. We know that there's a lot of areas they simply, their hands are tied, but we're looking for areas that we can utilize their expertise and then get those out to you. So stay tuned. We're probably looking at end of first quarter next year, beginning of second quarter, that we may be able to start rolling some of those out. Next slide, please. And very good. All right, so today a lot of questions have come in lately about in-house pharmacies. I've done some very, very brief discussions on that in different presentations. We're running a little short on time today, so I'll probably abbreviate even some of this. But if you have further questions, feel free to reach out to me via my email or give me a call. I think most of you know how to reach me or connect on Noddlepod, and I can get a hold of you that way. Next slide. So a lot of folks think, man, I want an in-house pharmacy. The health center, 2 cities over has one, and they're bringing in some additional savings of $750,000 a year, and they bought a mobile dental unit and all of that. We should have one too. I want you to know that an in-house pharmacy isn't necessarily the right thing for every health center. So we're going to run through, is it feasible for us? But some of the reasons folks want to have an in-house pharmacy is, first off, you definitely could see an increase in return on your 340B savings, because you will avoid some of the dispensing fees and some of the admin fees that you see within contract pharmacies, especially with some of those contract pharmacies that have 50% profit sharing involved with them and other things. You can get away from that. So you'll definitely see an improvement in your bottom line. The other thing that I think is as important, I'm not going to say more so, but certainly as important, is you have better control over your patient outcomes. Your pharmacy staff is able to work directly, face-to-face often with your patients to improve adherence and compliance to their medication strategies. And this is one part that I think is so important, is that you set the standards for pharmacy care. You're not simply trusting Bob down at Bob's Community Pharmacy or the pharmacist of the week down at Walgreens or CVS, that they're going to treat your patients the way they should be treated. So you, as a health center, then set that standard for how your pharmacists and your pharmacy staff will care for your patients. I know that some of you are work with contract pharmacies. You've run into issues in the past. That's something that can be avoided. You know, sometimes contract pharmacies aren't real good at paying you. With an in-house pharmacy, that's not going to be an issue. And the last thing that I think is a real pro is that if you consider being an open door pharmacy, that gives you an opportunity actually to attract some outside patients that may be living in the neighborhood around you, to serve your staff who may not see your providers in-house, and to serve families of patients who are established patients at your health center. Next slide. Some of the reasons that it may not be the right thing for you is that health centers inherently are very good at managing medical, dental, and behavioral health. Pharmacy is a whole new bird. It is very, very different. Health centers know how to hire for medical. They know how to retain dentists. They have very little understanding of all of the regulatory concerns and other things that are involved in putting an in-house pharmacy in. There's also some liabilities there. Now, while for our patients, we're covered as far as the Federal Tort Claims Act is going to protect us from any sort of liability being sued, that, but especially for Open Door, we need to protect ourselves by having adequate insurance in that aspect as well. There's also some pretty high startup costs. As you know, with a contract pharmacy, there's basically no startup costs. With an in-house, there's a variety of things here, and I won't go through each of them. One of them that's kind of significant, this is not so much in the cost as the effort, would be registrations, licensing, and contracting. You need to get NPIs, NCPDP. That takes quite a while, the NCPDP. State licensing, your DEA, PBMs, getting those PBM contracts. I just helped a pharmacy, a health center in Michigan. This was the first time in probably 14 years of helping health centers open pharmacies that I got the big three came back to me with no changes. And I actually got CVS Caremark in about 5 weeks. Unheard of. So I'm not going to say it'll ever happen again, but these are complicated things that if you're not familiar with the paperwork and what they're looking for, it can take a very long time to get this done. You need to determine, will you have TPA services for your in-house pharmacy? Many in-houses like to do that. They feel more comfortable. They feel protected doing so. There's some additional resources within your health center that you'll utilize as well. Next slide, please. So these are the determining factors. So the title of this month's office hours was the feasibility of an in-house pharmacy. The first three that I'm going to discuss really are going to tell you, is this feasible for us? Is this something that we should even consider? So the first is site selection. You need to have this critical mass of patients at the site where your pharmacy will be in order to ensure you'll have the volume necessary to be successful. So let's say you're a health center, you've got 20,000 patients, but you've got 10 sites and you've got 2,000 patients at each site. None of those sites are really going to provide you the volume that you need in order to be successful. Now, let's say you've got 20,000 patients, 10 sites, 7 of those are school-based sites. You've got a primary site that's seeing 10,000 patients, and the other sites cover the rest of them. Now you've got one site with 10,000 patients. That's definitely a critical mass of patients that can just physically provide you enough prescriptions. There are folks that say, well, people will come from our other sites. They'll come from the Battle Creek site, or they'll come from the Adrian site. No, they won't. Only under dire need, often for sliding fee or EPAP prescriptions, will patients do that. Patients more often than not are going to go to the closest pharmacy to where they live or shop. So we have to make sure that our in-house pharmacy is at a site where we get lots of foot traffic from our patients. The next thing that you have to consider is your payer mix. What percentage of your payer mix is uninsured? Now, I'm not going to say don't open an in-house pharmacy if you've got 40% uninsured, because, you know, right now, a lot of those folks may not be able to afford getting prescriptions at a contract pharmacy, even though you're doing it at acquisition plus dispensing fees. They may still not be able to afford that. So you need to understand an in-house pharmacy for a large percentage of uninsured patients still could be a very important investment for your organization in patient health. Also, you got to look at Medicaid and Medicaid MCOs. This is all going to be state dependent. With fee-for-service Medicaid, as you all know, you only are going to get reimbursed your 340B acquisition costs plus a professional dispensing fee. That's not bad if fee-for-service is a small portion of your overall business. But let's say you're in one of those states I talked about earlier where they're trying to merge managed care into fee-for-service. If suddenly 60% of your prescriptions are only going to get reimbursed at acquisition plus a professional dispensing fee, that's a very different story. It's hard to really get by on $8, $9, $10 dispensing fees only. You've got to have some 340B savings, some margin in there. So that's where you look at your Medicare or your commercial plans. Ideally, I really like to see a mix of Medicare and commercial somewhere in 25 to 30% range. I looked at one today that was over 60%, and I thought, oh my, you know, that's a permission to print money almost, because that's incredible to have that high of Medicare and third party. So you've got to put all of that together. Do we have a good enough mix? Do we have enough Medicare and commercial claims to support our uninsured program? Or do we simply want to have an in-house pharmacy and we're going to supplement it from other areas within our organization because we feel it's the best thing for our patients? The last one is prescription volume. And prescription volume and payer mix kind of go hand in hand. It's great if you have a whole ton of insulin prescriptions that you can fill, but if 90% of them are for your EPAP patients or your sliding fee folks, you really aren't going to generate any 340B savings. On the other hand, if you have a lot of diabetic patients and you are at 30 or 33% Medicare and commercial, you have a much better chance of bringing in some 340B savings to supplement your uninsured or your Medicaid programs. Realize when you open an in-house pharmacy and your goal, most of our goals with in-house pharmacies, you want to get at least 50% of the prescriptions written filled at your in-house. Let me tell you, that is not going to happen the first month you open or the first 6 months, and probably not even within the first year. this is a slow build. But realize with each day that you have an in-house open, you're generating additional prescriptions because probably half of the scripts that come into you are going to have refills. So you know that each day, those prescriptions that come in, you'll fill today, but then next month you'll also get a refill. And at the same time, you're getting those one-time fill, those antibiotics or those eye drops or whatever it might be. Eventually, you get to a point where you have a mix that's roughly 50-50, 50% refill, 50% new prescriptions. Now, I talked about the prescription volume a little bit here in brand mix too. I know of Ryan White clinics that have an in-house pharmacy that fill 30 to 40 scripts a day, and that's it. These folks make $1 million in 340B savings a year or better. But that's because their mix of brand and generic is heavily weighted toward the brand side. A lot of the HIV products are going to be brand name, and because of that, there's significantly more 340B savings. So that's another thing that you'll look at in your organization's prescription mix. Next slide, please. After that, some things you want to consider would be initial inventory. I put down here, depending on the model, 30 to 60,000. I've seen numbers that go as high as 100 or 200,000. I'm not sure who would spend that much on initial inventory. But I know of a health center that was open door. They were going to manage it under a replenishment model. So they purchased everything on retail and they opened their pharmacy with about 60,000. I'm working with a very small pharmacy right now. They know they're only going to fill maybe 50 or 60 scripts a day. They're only going to purchase 340B drugs. They're going to do a separate physical inventory and purchase a few psychotropic behavioral health meds because there's an in-house behavioral health there that they'll keep as separate. So their total inventory is probably going to be 15,000. So just realize this 30 to 60, that's a range. It could actually be 30 to 90, depending on how heavily you want to be stacked and if you're going to be a replenishment model virtual inventory. Just know wholesalers will give you terms, meaning they'll do this initial order. And most of them that I've worked with, you can get like $50,000 in the initial order, and you don't have to pay that for 6 months. And then you pay a sixth of that over the following 6 months. So they understand we have to wait to start generating PBM checks in order for us to pay them. So make sure you talk about them about that. For those of you who are non-pharmacists, non-pharmacy people, I'm speaking to C-suite and others out there. Staffing is going to be a significant expense that you need to keep in mind. I feel it's real important to tell folks that pharmacists are highly trained, highly sought after medical professionals. You're not going to find a pharmacist for the most part for $70,000 a year anywhere that I know. So realize and look into this, find out what the community norms are for pharmacist salaries, because that can be very, very significant, a big chunk of what your expenses will be in that first year or two as you're building business. Then you've got a variety of other financial considerations. I ran through some of these, and looking at the time, I'm not going to go into these any deeper. But realize you need to calculate where your break-even point is going to be based on everything you're going to put into this. How long is it going to take you not to have to be supplementing your pharmacy to cover your salaries for your tech and your pharmacist and other things? So make sure that you count the cost prior to doing this. Next slide, please. Lastly, so many folks after hearing this may now say, geez, maybe this isn't the right thing. I really want one, but we just don't have the volume. What I want you to think about is continue your contract pharmacy arrangements or set up contract pharmacy arrangements if you have none now. I don't want what's happening with the manufacturers to hold people back from gaining some level of 340B savings. If right now you have no contract pharmacies, you're gaining 100% of nothing. So go out there, get something, because there's 340B dollars waiting for you. And HRSA expects that you're going to take advantage of this. So while you may not be getting as much as you would have a year ago, if you're doing the right things like moving patients to medications that are being provided to contract pharmacies, and take a look on NoddlePod. There's a post that Jenga's put together for us on equivalent meds that we can move patients to. I just don't want you to hold off going to a contract pharmacy and setting that up just because you don't know what's going to happen with manufacturers. Whatever happens with them, there's still 340B savings for you to gain, and there's no investment to get started with that. And lastly, if you simply decide we do have the critical mass, we do want to do this, but we have no skills, I don't want to get involved in all of that pharmacy stuff. There are organizations out there who will either do an in-house contract pharmacy model, or they'll do all the build out and the contracting in your name, and then manage the pharmacy for you. The way that they do that, ideally, you as the health center hold the licenses. That way, it's not a contract pharmacy, and you're able to continue to get all the medications that you need. But you're either going to pay a flat monthly fee, a percentage fee, or a combination of both. So those are some alternatives if you determine that in-house is not right for you. So that is what I have. I don't think there's any more slides. If you could check, Brandon.
I think it's just to questions now, Tim.
Okay.
You can hear me, right? Okay.
I do hear you.
But we have a question here for you. If a patient only sees behavioral health providers at a CHC, can they use the in-house 340B pharmacy? Somebody was confused about something that said.
You know, I have always felt that if someone comes to my health center for dentistry and doesn't see our primary care providers and brings us prescriptions for a different provider, no, those aren't 340B, but anything dentistry would be. I would say any of the behavioral health scripts, if it is in fact your providers, those providers are either employees of, under contract with, or you have that referral arrangement in place with the behavioral health that's on site, then yes, definitely any of those behavioral health scripts could be filled at your in-house pharmacy. It's just, if they're not a patient of your pharmacy, they're a patient of behavioral health for 340B. They could bring in other prescriptions, but you would have to separate that from 340B if they brought in medical or dental from providers not of your health center.
Mm-hmm. And just to add to that, these issues are so incredibly gray. We used to call it 340 shades of gray. So if you're looking for like a clear-cut answer definitely on that, you're not going to find one. I would say that if the person comes in for behavioral health and you really feel like you want to be filling their high blood pressure medication or whatever, try to get them in with one of your primary care providers. That's good for integration to begin with. And if, let's say they have a specialty drug, then you want to have a policy in place to say, okay, in these circumstances, the standard that HRSA uses is that the health center or other provider must have responsibility for care, for the patient's care. So you should have some way of showing that you have a provider that is in some way assuming responsibility for these other non-behavioral health scripts. But as I said, if you're looking for a clear-cut, black and white answer, there isn't one.
And Colleen, just having one of your providers sign off on it, that doesn't work. That's diversion, because there's nothing in the record that they are being seen for hypertension at your health center. And that's the bottom line. There has to be documentation of care.
Right. If you want to give Mike Blom and Jason Reddish a heart attack at Feldsman Tucker, have your doctor rewrite prescriptions that are written by a specialist. Not only do you have 340B problems, but you have way more important liability issues going there. So please do not do that. Another question came in. How about a clinical pharmacist? Can prescriptions be filled 340B? I'm not entirely sure I understand the question.
I can.
Do you understand that?
Colleen, this is Jenga.
Can you open Jennifer's line? Oh, okay. Oh, okay, great.
I think they're referring to, so in some states, pharmacists have the ability to prescribe medications through collaborative practice agreements. And from, at least in Ohio, and I believe in the majority of states where that's the case, that it has to come from a referral from a physician or nurse practitioner if they allow it in the first place. So like the physician or nurse practitioner will have to have a medical assessment for that diagnosis and then refer to care for to the pharmacist to manage the prescription. So in our clinic, doctor sees them for diabetes, diagnosis is there, they refer to us for management. We send prescriptions and prescribe medications and order labs, and those prescriptions do count as 340B, but we don't see new patients who have not been evaluated at our health center previously.
Mm-hmm. And another question related to that, how long after a visit does a prescription still count as 340B? Another one of these
365 days. The length of time this prescription's good.
Policy and procedures.
Yeah, I guess the prescription itself. Yeah, but I would also say, as Jenga said, policies and procedures, it's really important in all of these gray areas to have a policy and procedure that lays out, like, for instance, you know, how long will we keep refilling a prescription if the person hasn't come back in? It's almost more important that you have a policy and you stick with it in these gray areas than what your specific policy is. I mean, obviously it has to pass the lab test. But I would say that, as Tim said, if the patient is still one of your patients and the prescription is still within the 365 days, you're okay.
Yeah,
because that kind of goes back. Go ahead, Jengus.
Oh, sorry. I was just going to say, you know, Tim was mentioning about the how long is a prescription good for normally, even outside of 340B. But I think with policy and procedures, especially in place of the pandemic, when state boards of pharmacy are making exceptions to allow retail pharmacies to honor or extend the refills of a prescription beyond, you know, beyond 12 or possibly beyond 365 days, but depending on the state or the, because they know that people may not be able to get into their prescribers during the COVID pandemic. So I would just make sure that your policy and procedures allow for the eligibility in the event of a public health emergency when there's these exceptions on the state level, and where it could be longer than 365, even though almost typically by law, no, it wouldn't.
Mm-hmm.
This is Mike. Can I say something here?
Go ahead.
Did we save you from a heart attack?
Yeah, I just wanted, I kind of want to, yes, that was good. That made me feel so much calmer today. Yeah, I think that Jengus's point is right. I mean, if an auditor looks at a script for 340B, the first question is going to be, you know, was it written by a provider, et cetera, et cetera, et cetera. The refill thing is really a question of how long the state law or the prescription allows to be filled in the first place. And as they pointed out, a lot of them are a year, sometimes they're shorter. But as long as you've got that chain and it's meeting state or other requirements for the refill, it shouldn't be a problem with 340B as long as you can still document that there's something in there that shows that you're responsible for the care. For example, after a year, usually, at least the ones that I have, the doc wants to have some encounter, something to say, yeah, how are things going, or you want to do this. Put that in the record, and you should be fine for 340B throughout. Whether or not that meets the standard in the state law for prescribing a refill is a different matter. So usually it's 365, but it may be more or less, and then we have these extensions, which is different than the 340B eligibility. That's all I have to say. I mean, the first question is it a legal script under prescribing practice on state law? Then the second question is the connection there with the health center still strictly sufficient to be able to document that this is a legitimate patient of the health center?
Jennifer chatted back about the clinical pharmacist and it's establishing a new patient. And I think that comes down to, again, policy and procedures and also your state laws. As long as you're following the appropriate state laws and have it documented in your policies and procedures, I think it's fine. We just have to show that we're maintaining that care and that they're a patient of the health center. And if you're doing that within that medical record, I think you're fine 340B wise.
Yeah, I also agree with that. It varies by state for sure in terms of what a pharmacist can do by writing a script. If the state law says the pharmacist can essentially diagnose and write the script, as long as they have that connection with the health center, you should be fine. You are fine with 340B.
All right. Are there any more questions? I know we're running over time. So before we close our session, I want to reiterate, I put a little note in our chat. So we will be working on the technology moving forward. So hopefully have that rectified moving forward. But I did want to send a huge thank you to Colleen for all your contributions to NAC and the support that you provided us, and certainly to me. So huge kudos and applause to Colleen. Sad that you're leaving NAC, but happy that you're still going to be in the health center world. So we'll still be connected that way. So thank you, everyone. And my emails are in the chat. Tim's emails are there as well. So if you guys have any additional questions, please feel free to fire those away to Tim and I. All right. Have a great afternoon.
Bye, everyone.
Right.